All right, so what did we think of Marie's presentation? How do you feel about Arrestin and your confidence in trying it, using it, explaining it to your patients?
I really like that video that she showed us.
It's really cool, and patients respond really well to that.
I'm really glad we got to learn about it before we were in the clinic hands-on.
I agree. I think it's really nice to see this one. This is one you kind of need to know about before you start using it.
Also, clinic was good yesterday.
Good. What have y'all gotten to do in clinic so far?
Yesterday we did gingival assessment and periodontal assessment, and next time we're going to do calculus detection.
Ooh, okay, good. So I'm glad we kind of got through those. Chapter 20 was about clinical assessments. I'm glad we did that sooner rather than later. That's why I moved it up so far. I knew y'all would be doing that in clinic before we got to it if we went in the order that the book has. Okay, so I'm still accepting responses about office hours. I apologize that I have to kind of cancel Tuesdays before class. I'll be available right before, but I just cannot make it work with my schedule. So y'all are welcome to ask me for a meeting at any time. I'm available outside of office hours. We just need to schedule something. So don't think that that's the only time you can contact me. Okay, I'm going to start sharing my screen. And then after today, I'm happy to stick around and go over the most commonly missed questions from the exam. I'll leave it on the recording in case you have to go. That's okay. You can watch it later. Okay, was everybody able to get the handout and the PowerPoint for today? Great. Okay, so your assignment for this course, for this lecture period, is actually going to be a quiz over Arrestin, and you get two opportunities to take it. So the first one, I just want you to see what you remember. Try to take the quiz without looking anything up. And then the second one, you should be able to get 100 because you should be able to see the correct answers the first time, okay? So moving into periodontitis, I know some of that probably sounded a little foreign because we haven't covered this chapter yet, but I think after this, it'll make a lot more sense. Here are your objectives, again, straight from the syllabus. So what are we going to talk about? Periodontitis, the name of this course, periodontology, right? This is what you and I specialize in. Do you know how long dental school spends on periodontitis? How long dental students spend on learning how to do a scaling and root planing? 2 weeks. The dental school in San Antonio spends 2 weeks. This is our specialty. This is why we do the cleaning instead of letting the dentist do all the cleanings, right? Not to down talk any dentists, but this is our specialty. So what is it? First, we have to talk about what it is. What did we say itis means?
Inflammation.
Inflammation, and then periodonta, inflammation of the periodontium. So what tissues are included in the periodontium?
The gingiva.
Good, the gingiva.
Alveolar bone.
Good, alveolar bone. What else?
PDO.
PDO, good. So it makes sense that in periodontitis, we would see inflammation in all of these structures versus gingivitis, where we see inflammation in the gingiva only. Your first blank here, the definition, periodontitis is irreversible. This is no longer a reversible process. Now we're into irreversible damage, and it's going to continue progressing until it's treated or the teeth fall out. So there's this old saying, long in the tooth. Has anyone ever heard that? That someone is long in the tooth? Basically, it means it's like an old way of saying you're old. Because people thought their teeth would get longer as they aged, but in reality, their periodontitis got worse. So their teeth appeared longer because they were losing attachment over their lifetime. So if we don't stop this, it's just going to keep going. And we said last week, apical migration of the junctional epithelium is the major differentiator here between gingivitis and periodontitis. So Marie talked about this a little bit with the Arrestin presentation, but we know over half of Americans have gum disease, have some sort of periodontal disease. Is it more than that? Yeah, absolutely. This is a really old study from 09-10, from 2009-2010, and they haven't updated it yet. So this number is just the number that we found and could estimate. But you and I know most patients have bleeding, pocketing, something going on to cause periodontal disease. Once a patient's treated for perio, they will always be perio. They never ever go back to a prophy, because who is a prophy for?
Healthy gingiva.
Healthy patients. We can never say that periodontal health is reestablished. Gingival health can be reestablished, but never periodontal health.
So they'll never get a prophy.
They'll never get a prophy again. They will always and forever be a periodontal maintenance.
So if they're like keeping up with their appointments and trying to maintain it, why would they not ever get a prophy?
A prophy is for patients with no attachment loss. So health, they have to have periodontal health. Now, periodontal maintenance is the version of a prophy for patients who've had periodontitis and are, their disease process has been arrested.
So what would happen if you were to prophy a periodontal patient?
That's insurance fraud.
Oh,
But
okay.
don't panic. Everybody does that. A lot of offices do that because patients don't want to pay for a periodontal maintenance. But this is where our job comes in, explaining why they need a perio maintenance instead of a prophy. Well, don't say this to your patients, but you let your periodontal status slip and now you have to pay for a more in-depth cleaning. We're trying to maintain and prevent further disease.
So that would be like the scaling and root cleaning appointment?
If they have active perio, yes. If it's active, they would require a scaling and root planing. If we're just maintaining or they have gingival involvement on a reduced periodontium, then we can go with a periodontal maintenance. Good question. Okay, so this is what perio looks like. And remember the two ways that a periodontal pocket is formed, right? We have a pseudo pocket and a true pocket. So you can see in this picture, there's definitely some inflammation in the interdental papillae, but there's also apical migration of the junctional epithelium. We're definitely seeing where we've lost attachment on this tooth. And then we can see that on the interproximal view, like let's just say this is mesial. When we probe, this is why we have to use a walking stroke, right? How many different probing depths could we get once we divide this into 3 sections, right? One here, one here, one here. So this is why we use a walking or bobbing stroke to detect any of those deeper areas within the sulcus. Now, there are 2 different classifications we're going to talk about in just a little bit, 1999 and 2018. Some of you weren't even born in 1999, which blows my mind. That's fine. So this came out in 1999, where we had a really great classification system for the time being. It's recently been upgraded, but we're going to learn about both. So periodontitis, what does it look like? Remember, we talked about 2 different characteristics. If it's edematous, what does edematous mean?
Fluid filled.
Yeah, swole, right? Fluid filled, swollen. We're going to get swole. Our gingiva puffs up. So this is when we see usually red to purple color of the gingiva versus fibrotic. So you can see the difference between these two pictures, right? Excuse me. This is fibrotic, pink, long-standing periodontitis at the bottom. This is a more acute process of periodontitis where it's still red. So sorry. Woo. The texture is usually smooth and shiny unless we have that fibrotic appearance. That would be your texture. Our consistency is usually spongy and edematous, where we can just like push on it and it doesn't rebound like it should. It's not as resilient as it should be.
I have a dumb question.
There are no dumb questions.
Could a patient have gingivitis and perio?
So yes, what we would say is that they have gingival disease on a reduced periodontium. So the gingival inflammation can be reactivated even if the patient has been treated for periodontitis before. Good question. That's not a dumb question. Y'all ask your questions. I love it. Interdental papillae, they can be bulbous or blunted or both, right? On the same tooth. The mesial surface can be blunted while the distal surface is bulbous. So this is where our descriptions and being very specific comes in. The gingival margins, we can see recession, we can see rolled, we can see all kinds of different things for those gingival margins.
Miss Mitchell, I'm
Yes.
sorry. I'm just like blown away with that bulbous and stuff because I was told I had bulbous gums. I was like, I floss my teeth on a constant basis and stuff. I said, what's bulbous? And then that's why I was like, that's bulbous.
This is bulbous.
Yeah, I don't have that.
No. I don't know. We'll see. I mean, sometimes you can have just one or two spots like that you nicked with the floss or brushed too hard and it can be, you know, bulbous for just the day or, you know, hormones, different things can affect it. But generally bulbous is like definitely like you can see that's too large.
Now I can say that I may have some recession, but not that. My gums are nice and pink. For those of you guys who worked on me, you all know that. Miss Alana does not have that. See? Thank you, Megan. I have some healthy, and I was told yesterday I had bulbous and it was purple and red. And I said, excuse me? And then I said, I'm dead. Okay.
You don't know. You couldn't see. Maybe they should take an intraoral picture and show you next time.
I'm OCD when it comes to my teeth. I may be having missing ones, but I paid for them.
I am too, but sometimes I have bulbous
in my
papillae.
mouth. Yeah, you can take a drive in this one.
But that's the thing, you know, if there's just one area with a bulbous papilla, we need to list that and say, you know, bulbous papilla localized to number 27 interproximal or something like that. Okay, moving forward, bleeding we can describe as light, moderate, or heavy. What point would a patient not have bleeding during periodontitis?
Smoker.
Very good. So unless there's an underlying cause for reduction in bleeding, we will see bleeding. Gingival crevicular fluid, remember, is increased during disease processes. Sometimes we'll see exudate. It's not nearly as common as seeing more bleeding, but you may see pus in the pocket. Now, this is where it gets interesting. Plaque. We have mature plaque biofilm deposits present in pockets with periodontitis. And then, of course, we can see mobility and furcation involvement depending on how advanced the process is. So, characteristics. This is going to blow y'all's mind. I don't know if you've already talked about this, but this is usually something I get a lot of questions about. So if you have questions, let's go over it. There is a difference between clinical attachment loss and clinical attachment level. So when y'all are looking at Dentrix, and yesterday you put in your periodontal chart, right? And you see P, D, G, M, Cal. PD stands for pocket depth. GM, this is where you would enter either recession or hyperplasia or a 0. If patients have no recession or hyperplasia, we put a 0 there. And then Dentrix automatically calculates that for you, which is beautiful. I love that. And then it'll even turn red if it's above, if it's a 4 or above, it turns red. So clinical attachment level, that's what Dentrix is calculating for you. Anytime there's a calculation, if you have to add or subtract, we're talking about clinical attachment level. So everybody on every single surface of every single tooth has a clinical attachment level. In health, what do you think a clinical attachment level would be?
No more than 3.
Good. 1 to 3. Now, clinical attachment loss. Does every patient have clinical attachment loss? No. Otherwise, nobody would ever be healthy, right? So this is an easy way to determine which one we're talking about. And a lot of textbooks use this interchangeably, but I want you to understand it's not interchangeable. Clinical attachment level. Everybody has this. Clinical attachment loss is only in periodontitis patients or traumatic responses, right? That causes attachment loss. So this is where we have to see the apical migration of the junctional epithelium, destruction of gingival fibers, destruction of periodontal ligament fibers, and loss of alveolar bone support. Clinical attachment loss, you could say in periodontitis, is equal to the amount of recession that a patient has. So what is the actual loss of attachment? So let's review. Where should the gingival margin be?
At or below this, or right at the CEJ.
The gingival margin.
It's above. It should be up on the top over around the coronal crown.
Okay, so coronal to what?
The CEJ.
Good. 1 to 3 millimeters coronal to the CEJ. Good. Okay, and where should the junctional epithelium be, Lexi?
Right at the CEJ.
Good. At or near the CEJ. So this is how we get our healthy pocket, 1 to 3 millimeters. If the gingival margin is greater than 3 millimeters coronal to the CEJ, what disease process do you think we have going on? So if the gingival margin is greater than or equal to 4 millimeters coronal to the CEJ, what kind of disease process is that?
Gingivitis.
Good, gingivitis. This is where we have gingivitis. If the gingival margin is apical to the CEJ, what disease process is that?
Recession.
Recession due to trauma or?
Periodontitis.
Good, periodontitis, very good. So you can see how just that description of where these structures are within the mouth makes a lot of sense, right? If you understand that very basic anatomy of the periodontium, then with any question we can determine whether the patient has attachment loss, gingivitis, periodontitis, health. What process are they currently experiencing? Any questions before we move forward?
I did have one question.
Sure.
So like on the activity, it was labeling like the 3 millimeters as gingivitis. So we consider 3 gingivitis.
3 millimeters, what? Of hyperplasia?
Okay, so it has to be hyperplasia.
Yeah. So that's a really good question, Lexi. So pocket depth plus recession is usually seen in periodontitis. Pocket depth minus hyperplasia is usually seen in gingivitis. Gingivitis, I can spell, I promise. Okay. So if we have a pocket depth of 3 and hyperplasia of a 3, or I'm sorry, pocket depth of 6, hyperplasia of 3, we have to subtract that hyperplasia from the 6, and that still gives us, 3 millimeters for clinical attachment level, telling us we haven't lost any attachment, therefore it cannot be a periodontitis process. We're still in gingivitis, and usually we see hyperplasia, it's very rare to see true hyperplasia. We see 4 millimeter pockets a lot due to inflammation, but true gingival hyperplasia is like with those drugs we talked about, nifedipine, phenytoin, or cyclosporine. So the only time you'll really be charting hyperplasia is if the patient has gingivitis and has like 4 millimeter pockets, or if they really have that fibrotic extra connective tissue causing that enlargement.
Thank you.
You're welcome. Anybody else have questions before we keep going? All right, so that brings me to my next point. Clinical attachment level is always more accurate than a pocket depth. You could have a 6 millimeter pocket depth that reflects gingivitis or periodontitis. We don't know. We would have to see where is the gingival margin and therefore where is the clinical attachment level. So here's just a picture from Elsevier, what it looks like, how are we going to add? Now, it's not to scale at all because it says this is a 12 millimeter root. So, it's got a 3 millimeter pocket depth, 3 millimeters of recession. That means the level of attachment. You can see here, where is that junctional epithelium attached versus where should it be attached, right? That means we've lost 6 millimeters of attachment on that tooth. That's pretty significant. So this is just kind of a recap of the last 2 slides. How to calculate clinical attachment level. I promise you I will ask you about this on an exam. Write it down. And then remember, not everyone has clinical attachment level loss. So I kind of like to think of this as cal versus call. Clinical attachment level loss versus clinical attachment level.
Ms. Mitchell.
Which one are, oh, go ahead.
My question's back in the characteristics one. I'll let you finish this first one and I'll say it, because it's about.
No, you're fine. About the blank for plaque and calculus.
Yes, ma'am.
It's mature plaque because it's been there for a long time. So it's got some nasty bacteria in it.
So it's not calculus, but it's old plaque.
Well, it may or may not have calculus, but we need that plaque in the pocket to initiate the disease process. So even if there is calculus present, what is calculus always covered in? Plaque. So the presence of calculus doesn't determine whether or not the patient has disease. It can contribute to disease, but it doesn't cause it.
Okay. That makes sense. Thank you.
You're welcome. Okay, let's talk about some more cow. So, the clinical attachment level determines whether or not a patient can clean a pocket at home. In an office, in general, you and I can effectively clean up to about 6 millimeters. 6 millimeters. Now, can a patient clean a 6 millimeter pocket at home? No, there's nothing that they can do at home to clean a 6 millimeter pocket. So this is why we need to keep track, arrest, and prevent future disease. So the symptoms, it's painless. You need to know that it's painless. And this is why people don't seek help for periodontitis. It doesn't hurt. So they think it doesn't matter, or they just don't know it's there. Onset, this can happen at any age, literally. We can see it in kids as young as, 6, sometimes younger. It's very rare, but we can see it. However, it's most common in adults and older adults. And the prevalence and severity is going to increase with age. There are a couple different reasons for that. It's not necessarily that patients who are older have more susceptibility to periodontitis, but generally it's been a long-standing process that's been going for years and years. And remember, because it's episodic, we actually see that, over time they have more and more loss. Now, patient education, y'all are educators. You have to educate your patients on periodontitis, how to treat it, and how to prevent future infection. So the absence of pain doesn't mean there's no issue present. We have to recognize clinical signs very early. What are clinical signs of disease in the mouth?
Bleeding.
Bleeding.
Bright red, inflamed.
Good. Redness, inflammation. I cannot tell y'all how many patients think it's normal to see pink in the sink. All that means is blood. When they spit after brushing or flossing, they think it's normal to see blood. It is not. We don't want that. We don't want pink in the sink ever. So extent. Take this slide with a grain of salt. Periodontitis can be described as localized or generalized. That's a descriptor. All that's going to do is help us determine what kind of treatment the patient needs. It doesn't determine the severity of their disease. This is only the extent, how much of their mouth is involved. A third or more than a third, less than 30% or more than 30%. 30% is our marker here. Now, progression, this is where it gets interesting. Periodontitis is an inflammatory condition. It's caused by inflammation. It is not constantly progressing because it is episodic. So remember, we have the host response, right? Our immune system is like, hey, I can handle that. I can handle that bacteria. And the process stops for a while. But then the bacterial load gets heavy again, and we see another inflammatory process. I'm sorry I covered this word. I didn't mean to do that. It's just untouched. So episodic means we have bursts of activity and periods of remission. Sometimes it's active, sometimes it's not, and that's dependent on our immune system. It's also site specific. So this means that periodontitis does not progress at the same speed at every site in the mouth. We might not even have periodontitis in some sites, right? So our outcomes: halt disease where it's at and prevent further destruction. Can we expect patients to regrow bone, to regrow the PDL? No. But we can stop it where it's at, and it's really important to explain that to patients. So let's briefly discuss the pathogenesis before we get into the classification systems. Collagen, what is collagen?
It's the, it gives you like, I want to say like in your car, it's a brake pad or something.
Okay.
Elasticity.
Yeah, elasticity, nice. So we are all ladies here. And for those of you who are below 25, you can't participate in this conversation yet, but when you push on your skin, right, you want it to look nice and supple and firm, right? Same with our thighs. That's a big thing. We don't want all of that, you know, we don't want squishy thighs, right? Even though, I mean, mine are squishy because I like to eat, it's fine. So collagen is what's giving us that bounce in our connective tissue. We have collagenous fibers providing, remember the jello that our epithelium is sitting on top of. Well, now we're losing that jello. It's kind of deflating. Looks like a deflated balloon, right? So those epithelial cells start to migrate apically. In the coronal portion of the junctional epithelium, remember our example, it's kind of like peeling away from the tooth here. Then the pocket has more biofilm, and the biofilm is causing inflammation. So now we have a deeper pocket. Well, then the junctional epithelium not only has peeled away from the tooth, now it's starting to migrate apically. We're starting to lose those gingival fibers, those periodontal ligament fibers, the bone. That bacteria is literally eating its way through our mouths. So biofilm causes gingival inflammation, causes pocket formation, which harbors more biofilm. It's a constant process. And remember, if a patient has a 6 millimeter pocket, they can't clean the biofilm out of that pocket, even with a water pick. It's not coming out of there. So it's our job to make it cleansable at home. So endpoints of therapy, this is our job. This is what we want to do. Eliminate microbial etiology and contributing factors. What are you and I eliminating during periodontal therapy?
Inflammation.
Inflammation by destroying what?
Infection.
Bacteria.
Bacteria, good. So we've got to remove the bacteria. And that means plaque, calculus. What are some other contributing factors we've talked about that harbor plaque biofilm?
Overhanging restorations.
Good, thank you, JC. Overhanging restorations. Ortho, right? Malocclusion, recession. There's a lot of contributing factors, and we'll continue to review those. Now we have to preserve the remaining structures. If a patient already has 2 millimeters of clinical attachment loss, we have to keep that from getting worse. And then we have to prevent it from happening again. So number one treatment goal, we have to get the patient to understand what's going on in their mouth. Then we provide periodontal treatment. We eliminate the local factors with the help of our doctor. You and I are not taking a high-speed drill to overhanging restorations. We have to involve the dental team with this. Then surgery if necessary. Remember, surgery is only necessary if we have failed with non-surgical methods, and a maintenance program. We have to explain to patients up front with periodontitis. You will be required to come in for 2 separate appointments to scale your entire mouth. You will be required to come in 4 to 6 weeks after completion of the treatment, and you will be required to come in every 3 months until you prove to me you can keep this clean at home. They need to know up front everything that they're getting into. Now, there are recurrent and refractory forms of periodontitis. Recurrent is very common, unfortunately, basically just a return of periodontitis that was under control. So if a patient is non-compliant, if they're not flossing or brushing, we're going to see reactivation of periodontitis. And again, our focus is arresting disease and maintaining health, whatever health they have left. Now, refractory, this is very rare. This is more, it's more common in people with like autoimmune conditions or some underlying cause. Continued attachment loss, regardless of appropriate treatment, adequate home care, and periodontal maintenance. Sometimes this requires the use of systemic antibiotics to get it under control. And these are known as downhill patients. How sad is that? A downhill patient. Don't ever say that to your patients. It's just for you to understand what this continuous process is, okay? It's always sad when I finish my coffee. Okay. Next, we're going to talk about classifications, and this is what you're going to be using in the clinic to track your graduation requirements. So for your requirements, we're going to use the 2018. However, the national board is still covering 1999. I want you to have a good understanding of both. And then if you don't need it, that's okay. But then you don't have to relearn something right before your board, okay? There's a method to this, I promise. They've been promising for about 2 years that they were going to take the old way out, and they haven't done it yet. So 1999, this is like the old way, right? Everybody's been calling millennials old on TikTok. 1999, this is the old way, right? Now 2018, this is the new way. This is just, you know, colloquial jargon that we use to say, are we doing this the old way or the new way? Instead of 1999 or 2018. So in the 1999, these are some of the major differences here. We are calling this localized or generalized based on that 30% less or more. We have chronic or aggressive perio, and this goes by case type. Don't worry, we're going to dive into this. We also have slight, moderate, or advanced. So these are your key words to understanding the 1999 classification system. The new way, we assign according to the worst site. We treat the mouth as a whole. If one spot is most involved, we're going to treat the whole mouth as if it's that involved. There's no longer chronic or aggressive periodontitis. There's a whole new set. Patients receive a stage and a grade, and we'll talk about complexity and severity based on that stage in just a little bit. So here is the chart. I'm going to go ahead and post this for y'all in Canvas. Write that down. So you can just like have it to print it if you want. And I made this, I adapted this, but what I've done is say the clinical attachment loss up here, that's these numbers, 1 to 2, 3 to 4, 5 plus. And then clinical attachment level. What are we going to be seeing on Dentrix for our clinical attachment level versus the loss? Here are the treatment suggestions based on what AAP case type the patient has, and then the follow-up suggestions. So let's talk about chronic periodontitis. This is still language you might see when you get to your national board. This is the most common form of periodontitis. What's the most common form of periodontal disease?
Gingivitis.
Gingivitis, good. Now, chronic periodontitis is the most common form of perio, not periodontal disease, specifically perio. And this is, again, per the 1999. It progresses very slowly and usually in a horizontal pattern. Again, localized, first generalized. And we have Mr. Perio present in these pockets. Porphyromonas gingivalis. I'm going to ask you to fill in the blank with Porphyromonas gingivalis. Did everyone hear me? P. gingivalis, it's Perio. The last time I taught Perio, one of my students' 3-year-old daughters came on the microphone and she said, P. gingivalis, it's Perio. And she still calls me to this day to tell me that. She FaceTimes now that she's a little older. So, Porphyromonas gingivalis, P. gingivalis, Mr. Perio. So bacteria creates a mixed infection. That's your blank there. Bacteria creates a mixed infection. And all this means is that there's all kinds of bacteria mixed into that plaque biofilm, mixed into that pocket that's causing different kinds of responses from the body. But P. gingivalis, this is a pretty bad kind of bacteria to have. This is just very slight chronic perio. We see a little bit of loss all over the mouth. All right, what pattern of bone loss are you seeing in this radiograph? Oh no. Thank you, Kaylee. What pattern of bone loss are we seeing?
Is it vertical?
Well, let's look. If we've got CEJ to CEJ, CEJ to CEJ, CEJ to CEJ, what are we seeing there? Horizontal, good. So we're seeing horizontal bone loss, and you can see in this photograph, it's pretty well present on all of the teeth. So this is a very characteristic picture of long-standing chronic periodontitis. Is that tissue edematous or fibrotic? Fibrotic, good. Is this a good bite wing? For a periodontal patient, can we see what we need to see on this bite wing?
No.
No, what should it be?
Vertical.
Yeah, we need a vertical bite wing for this patient. This is just not working for us. Now, aggressive periodontitis, this is no longer recognized as a periodontal disease per the AAP, but the 1999 way did recognize it. Aggressive is just what it sounds like. Progresses rapidly, causes a lot of destruction. We see massive, massive bone destruction. Our main bacteria here is Aggregatibacter actinomycomatans. You're going to see this as AA a lot. AA, aggressive perio. I'm not going to go into it too much. It's still localized or generalized. However, it's a different pattern. It's no longer going off 30%. So aggressive perio has a completely different pattern. Can you see the bone loss around the first molar here? Okay, but then look at between the first and second molar. Completely healthy, completely normal, right? And this is very, very typical of aggressive periodontitis. So localized means it only includes the incisors and the first molars. Incisors and first molars. And then no more than 2 teeth outside of that. Now, generalized, this has the incisors, the first molars, and 3 or more permanent teeth outside of those. So if we go back to this slide here, We see first molar, first molar, first molar, none up here. And then only in the anterior, right? So is this localized or generalized based on just these pictures?
Is it localized?
It's localized because it only involves, thank you, Maggie, it only involves first molars and incisors. There's no other evidence for us to suggest that it's a generalized aggressive process. This is what it looks like. We've got this like fiery red gingiva. Treatment, a lot of times we have to use adjunct antibiotics. And when I say that, I mean, in addition to treatment, adjunct just means like added on. So this is a major difference between chronic and aggressive periodontitis. A lot of times aggressive requires a systemic antibiotic. Now, y'all are getting ready to do your first local anesthetic injections tomorrow. Would anesthesia work on that tissue? No, why not?
Infected.
Because there's active infection.
Active infection. So what pH are we going to see in that tissue?
Above 7, no, below 7, right?
Yeah, it's going to be acidic, below 7. So that means that we can't get that influx of sodium ions. We can't get nerve depolarization. So we would have to actually give this patient an antibiotic, chlorhexidine rinse, and tell them to come back in a few days when it's better. We can't treat them that day. It would be extremely painful for them. The next one I want to discuss is refractory. This is known as an AAP case type 5, and you can see a patient with diabetes. They're having a really hard time getting that perio under control. What did we say about glycemic control and periodontal diseases?
Was it that they have to have their H1C under control?
Good. Their HbA1c has to be under control. And if it's not, we see more severe perio processes, right? So glycemic control and periodontal disease are related. We can't say that they're causative factors for each other yet. It's coming though, I know. This is an example of prepubertal periodontitis. I'm not going to test you over this, but I did want you to see what it looks like in case you ever encounter this. I've never seen this personally, but when we zoom in and look at that pano, look at that. They're just floating in the gingiva. There's no bone support around those teeth. Same thing up here. It's really sad. This is really, really sad. These patients will be in full dentures for basically their entire life. So if you ever see this, they need to get to a periodontist yesterday. Okay, now necrotizing. We talked about necrotizing ulcerative gingivitis. Now let's talk about periodontitis. A lot of those same characteristics stand. That fetid odor, that's kind of a keyword for nug or nup. We've got that punched out papillae, and then a pseudomembrane. What is that pseudomembrane made up of? What are we seeing in that pseudomembrane? Like right here.
Infection, pus.
Yeah, pus, dead white blood cells. So again, we can see this with stress, poor oral hygiene, smoking, malnutrition, immunocompromisation. A lot of times we see this in college-aged students or people going through extremely stressful experiences in their life. So your first blank for NUP is fetid odor. Your second blank, we see severe tissue necrosis. We have death of the tissue. The clinical appearance, it's really, it's going to stand out. The papillae are punched out. You see how it looks like somebody just took like a scoop and scooped it out there. We see the pseudomembrane, and then this is also associated with pain. Remember we said chronic periodontitis, there's no pain. Patients don't know that it's going on. NUG and NUP, they will know, and they will be in pain. So the reason we went over NUP here is because it was recognized in 1999, and it's still recognized in the 2018. We're running low on time. If you need to go at 3, that's totally fine. I'm going to keep going just so that y'all have this recording to use, because this is important stuff. Necrotizing ulcerative periodontitis. These are our major bacteria involved. T. denticola, P. intermedia, P. gingivalis, and the Fusobacteria species. What did we say these organisms are known as? Do y'all remember? Vincent's. These are Vincent's organisms. All right, so treatment for NUG. Again, we probably cannot get to that tissue that day. They're in pain. We need to get that under control. We can do chlorhexidine rinses. They may need systemic antibiotics. How do we know when a patient needs a systemic antibiotic versus a local antibiotic? What are some systemic indicators of infection?
Fever.
Fever, good. And then
Fatigued.
yeah, malaise. I feel like I'm playing charades, y'all. Fever, malaise, and then lymphadenopathy. Remember, if the lymph nodes are swollen, we have some sort of systemic infection involved. Lymphadenopathy just means swollen lymph nodes. Now, the 2 systemic antibiotics we're seeing used the most are tetracycline or metronidazole. If your patient has an allergy to doxycycline, minocycline, those are tetracycline drugs. So then we would have to use metronidazole. On to 2018. This one's fun. These are the diseases recognized by the AAP in the 2018 classification. Today, we are only talking about periodontitis. Tuesday, we talked about health, gingival diseases, and conditions. Today, we're talking about periodontitis, and these 2 we'll talk about later. So today, just this one. So the first one is pristine clinical health. How many patients have pristine clinical health? Really? Like none. This is very uncommon. We talked about gingival diseases and conditions. It still recognizes gingivitis as localized or generalized. And what I want to point out here is that this is still referred to as a case of gingivitis. We never want to tell our patients, oh, we just have a little bit of gingivitis. No, you have a case of gingivitis. It's a disease that we need to treat. I know you want them to feel better, but we got to be real with them. Now, gingivitis does not receive a stage or a grade. And we're going to talk about what that is in just a second. Gingivitis does not receive a stage or a grade. That's probably going to be a true/false question. Heads up. Necrotizing periodontal diseases are still recognized, but they're no longer referred to as aggressive. We've completely wiped out that terminology. Aggressive is no longer a thing. And you can refer back to the descriptions above for necrotizing diseases. I'm not going to read it all again for you. Y'all know, right? All right. Why did we update these? If a patient tells you they have stage 4 cancer, do you know what stage 4 means right away? Yeah, it's bad, right? So if we put dental diseases on the same scale as we do cancer, then we're going to be able to explain to them how severe something is. You have stage 4 periodontitis, and they're immediately going to think like stage 4 cancer. This is serious. We also needed standardization throughout the world. So this isn't just in the US, this is throughout the world. We needed personalized treatment. The previous classifications weren't working for about a quarter of patients, and that's just the ones we know about. We also have classifications for implant diseases, which is huge. A lot of patients have implants now, so we needed to catch up. I'm going to skip this slide because it's on the next few as well. Basically, when we talk about staging, this indicates the severity of disease. I want you to relate staging to severity. How severe is the disease in this patient's mouth? We can use clinical attachment loss, specifically interdental or interproximal clinical attachment loss. However, it's most accurate to use radiographic bone level. So when I flip to this chart, you're going to see in just a minute, I'll show you what I mean by that. Now, extent, remember with the old way, with the 1999 way, we said extent was based on localized or generalized. We can still use that as a descriptor. However, we are going off of the worst area in the mouth. If one tooth has one of these criteria, that's what we're going for the whole mouth. And it's difficult to move from stage to stage. So once you get to a stage 3, it's really difficult to move back down to a 2. So interdental cal, site of greatest loss. What is clinical attachment loss? Well, loss, not level. So what does this equate to? How much what on the tooth surface? Recession, right? How much recession does that patient have? Then we look at radiographic bone level. Lost it there for a second. Sorry, guys. Now, I know it's 3 o'clock. If you've got to go, that's totally fine. I'm going to keep going because this is really important. We really need to get through this. Just make sure you watch it later, okay? Complexity, probing depth, bone loss. I'm going to show you the next slide and it's going to make more sense. But if the complexity factors listed here are present, generalized throughout the mouth, then we're going to bump up that stage. So let me show you what I'm talking about. This is the document provided by the AAP, and y'all should have this in your clinic manuals, yeah? So once you go through all of the assessments, you are going to say, this patient is a stage blank, grade blank, if they have periodontitis. Active periodontitis is what's going to tell us what stage the patient is in. So interdental cal, site of greatest loss. We've got 1 to 2 millimeters, 3 to 4 millimeters, or greater than 5 millimeters. Radiographic bone loss. Now, this is only referring to the root. It has nothing to do with the crown of the tooth. We are only talking about the root surface here. and then tooth loss. Now, tooth loss due to periodontitis. How do we know if a patient lost a tooth because of perio or decay?
I have.
What do you mean? What do you mean?
You said something about how many of us know that of a patient that lost a tooth because of perio.
Well, but how do we tell the difference? If they have a missing tooth, how do we know if it's because of perio or decay?
Well, there's no attachment.
Okay. So if it was due to perio, chances are the teeth around it also have some attachment loss, right?
Right.
Okay. How about their caries risk? Can their caries risk help us determine whether that tooth was lost to perio or decay?
No.
It might. It can contribute. It won't tell us unequivocally, but it can contribute, right? If they got a lot of caries in their mouth and not a lot of bone loss, that's probably loss due to decay. We would just have to guess at that point. Patients don't usually know, unless it's something like, yeah, I knocked my front teeth on a table and knocked them out, right? That's definitely not due to perio, that's due to trauma. So these are our major factors up here in the light blue. Once we get down to this darker bluish gray color, the complexity, we need this in 30%, greater than 30% of the mouth. So this becomes tricky. If a patient has 6 millimeter pocket depth throughout the mouth, but they only have 3 millimeters of clinical attachment loss, because this 6 millimeter pocket is generalized, because we're seeing it in more than 30% of the mouth, we have to go up to a stage 3. Even though the clinical attachment loss isn't there, that complexity factor is bumping up their stage. Does this make sense to everybody?
So if they qualify for any of the complexity after their stage, you bump them up. So if it were to be like anything in stage 4, they would automatically be a stage 4?
Only if it's more, if it's generalized, if it's present in 30% of the mouth or more. And I do have some automatic staging factors coming up. That's a really good point, Lexi. Okay, this is where it gets a little confusing. If we see max probing depths of 4 millimeters throughout the mouth, but we don't have any clinical attachment loss, we still have to stage that patient. Can you hear me now?
All right, can you hear me? I'm sorry, my AirPods died. Okay. So if your patient has generalized 4 millimeter pockets, what do you think that indicates? 4 millimeter pockets without attachment loss.
It's in the stage of gingivitis.
Okay, it's gingivitis. And you're like, Miss Mitchell, you just said gingivitis doesn't get a stage and grade. This is the exception. There's always an exception to the rule, and this is the exception. If your patient has generalized 4 millimeter pockets without any clinical attachment loss, they are still a stage 1. So let's say you go through the treatment, they come back for a reevaluation, and they have all 1 to 3 millimeter pockets with no clinical attachment loss. Can they go back to a prophy? Yeah.
They can go back.
Yeah, Yeah, they don't have any clinical attachment loss making them stay at a periodontal maintenance. So stage 1 is really very unique in that it's the only stage that can go back and get a prophy again because it's indicative of gingivitis. So let's talk about radiographic bone loss. I took this little picture and I put some lines on it. So this first line here, this is the CEJ right here. And then these red lines mark thirds of the tooth. So if we go back to our chart here, we're talking about radiographic bone loss. Is it in the coronal third or the middle third? So when we're looking here at the coronal third, 1/3 is up to 33%. The middle third is 33% to 66%, and the apical third is 67% or more. Now, they throw in a wrench here. They say the difference between stage 1 and stage 2 when it comes to radiographic bone loss is it less than 15% or is it 15 to 33%? So let's look here. We have to add an extra line here in that coronal third. So from this, oops, this is supposed to say 15%. I'm sorry, guys, 15%. From this first red line of the CEJ to this 15%, we're going to call this a stage 1. From 15% to 33%, we're into stage 2. And then if we are into the middle third at all, we have at least a stage 3. Does that make sense? All right, so when you're looking at an x-ray, it's the same thing. You have to visually split the root only. The crown does not mean anything right now, just the root surface. So let's talk about some automatic staging factors. If your patient has vertical bone loss greater than or equal to 3 millimeters, they're at least a stage 3 automatically. Automatically. If they have a furcation class 2, they're automatically at least a stage 3 minimum. And I put these on your handout for you as well. Greater than 5 teeth missing due to perio is automatically a stage 4. And then less than 20 teeth or less than 10 opposing pairs of teeth is an automatic stage 4. And this is pulled directly from the chart, guys. Oops, right here. If a patient has, where is it? Less than 20 teeth remaining, that's an automatic one. Do y'all play euchre in Tennessee? Is that a thing? Have you ever played euchre? It's a card game. Okay. Anyway, there's this thing called a trump card, and I don't mean like Donald Trump. A trump card is like, okay, I play this and I automatically win kind of thing, right? And that's from a game called euchre. So these are, I call these our trump cards. If one of these happens, it's automatically at least that stage 3 or 4, depending on the criteria. Well, if there's automatic staging characteristics, then there have to be exclusions. It only makes sense. There have to be exclusions. So what are the exclusions here? Remember, we talked about gingival recession of traumatic origin. That does not contribute to periodontitis. So it will not matter. Where do we usually see recession of traumatic origin?
Gum lines.
Okay, on what surfaces?
Anteriors.
What surface?
Facial.
Facial, good. Facial or lingual. That's why we only count interdental cal. We're not looking at facial or lingual cal at this point. We're only looking at interdental. Presence of loss on the distal of second molars due to the third molar. What's going to happen once we extract that third molar?
The tooth above it is probably going to come down, and then the teeth are going.
It should still be in occlusion with this second molar. What's going to happen to the bone here once we extract that third molar?
Well, there's a hole there.
Yeah.
So
what is it going to be filled with? Bone. Yeah, once we extract those third molars, the body fills in that space with bone. So if you take a pano or a PA on a patient who's had previous third molar extraction, you're going to see that the bone fills in that space. That doesn't count towards perio. We would expect to see bone loss if we have an impacted third molar.
okay, I have a question.
Sure.
Why does it fill in with bone when you remove your third molars, but it doesn't whenever you lose any other teeth?
That right there, that's critical thinking, you guys. And I'm so excited that you asked that question. That's a really great question. Okay, so it's not due to a periodontitis process. There's no inflammation there, right? I mean, there's inflammation after an extraction, of course, but the bone is actually going to fill. It's very similar to what happens if you break a bone, right? The body's going to repair it. So to answer your question, we don't have loss of the alveolar height here, just the density. So the bone is going to become more dense after we remove the tooth, but the alveolar crest is going to remain, where it was. So that's a really, really good question. If we lose bone between the teeth here, this can, become more dense, which we would expect, but it's not going to grow coronally again. That's an amazing, amazing question. Well done.
Okay, so I have another question. So let's say we remove the third molar, that grows back. Then we remove the second molar. Would it continue to grow back? Or
the bone density would increase, yes, but you're not going to see it move coronally. You're just going to see the bone kind of like fill in. Yes. Great questions. Okay. We'll talk more about these exclusions later. I really want to talk about grading and then we can go. I'm so sorry. I know I go over late every time I talk too much, but primary criteria versus grade modifiers. Let's just go look at the chart. Primary criteria, radiographic bone loss or CAL. If we have no loss over 5 years, it's an A. If we have less than 2 millimeters, it's a B. And if we have greater than 2 millimeters, it's a C. How many times do we have consistent x-rays for a patient over a course of 5 years?
Every year.
But how many times do we have patients who keep coming back for 5 years in a row, especially in a clinical setting at school?
Hardly any of them.
Yeah, hardly any. So this is a really hard one to rely on. Direct evidence of progression is really hard for us to rely on. What you and I are going to look at more commonly is their percentage of bone loss divided by their age in the most involved site. I'm really bad at math. I'm just going to tell you up front, okay? I'll never lie to you guys, and math is not me. I'm not here for it. So let's say your patient has 50% bone loss. They've lost half of their bone support, and that they are 50 years old. 50 divided by 50 is 1. So where would that fall? Grade A, B, or C?
B.
B. They'd be a grade B. All you have to do here is take the percentage of bone loss, and remember, you can just do 33%, 66%. This is just an estimation. I don't need you to measure and tell me. Just an estimation divided by their age will give you a decimal, and then that's where you're going to fall into A, B, or C. Another way is the case phenotype. That's just a fancy way of saying, does the amount of plaque correspond to the amount of destruction that we're seeing in the mouth? If we see heavy plaque biofilm with low levels of destruction, how is that patient's immune system? Pretty good. So grade A, that's a slow progression. Do we see heavy plaque with a pretty moderate periodontitis process? That's a moderate rate. Do we see a little bit of plaque and a lot of destruction? That's rapid, and that's where we get into C. Now, again, we have to have automatic factors, right? So if your patient is a smoker and or has diabetes, they automatically have at least a grade B. So a pack of cigarettes is 20 cigarettes. If they smoke a pack a day, automatically a grade C. If they smoke half a pack a day, automatically a grade C. If they're a social smoker, automatically a grade B. What about vape? I count vape too. The AAP has not made an official statement on this, but we know vape has more nicotine than cigarettes. So if they vape, they're at least a B. If they're vaping a cartridge a day, they're a C. If they use it occasionally, let's stick with a B, all right? And then finally, diabetes. If your patient has diabetes and their A1C is below 7, they're a grade B. If it's above 7, if it's at or above 7, they're a grade C. So these are automatic grading modifiers. So let's practice and then you can go. Sorry, this is a little case study I put together for us, okay? 45-year-old male. Now, males are more likely to have periodontitis than females, and we've talked about that before. It's probably that we think about our health more, right? No medications, negative medical history, normal vitals. No systemic factors linking to the periodontitis in this patient. Interdental cal is 1 to 2 millimeters. So interdental cal, the loss is 1 to 2 millimeters. Pocket depths are 3 to 4 millimeters. And he has generalized bleeding on probing. So these are really beautiful little spicules of calculus that I want to scale. Here's the CEJ relationship. Here's the bone level. What pattern of bone loss does this patient have?
Horizontal.
Horizontal, good. With an interdental cal of 1 to 2 millimeters, what is the 1999 AAP case type?
Stage 1.
That's the 2018, yes. 2018 is stage 1. Now what's the 1999?
B grade. B.
Nope. 1999 doesn't have a grade. 1999 is AAP case type.
A stage 2.
It'd be a case type 2. Yeah, AAP case type 2. So you'll see case type 2, usually we have to downgrade to get the stage because the 1999 AAP counted gingivitis as a 1. We don't do that in 2018. So if you slide the scale, most of the time they'll match up, right? Case type 2 is a stage 1. Case type 3 is a stage 2 kind of thing. So according to the information available, which of the following best describes this patient's periodontal status? Halt. Before you give me an answer, what can I cross out? With 1 to 2 millimeters of clinical attachment loss, what can I cross out?
Health.
The health.
Health. And?
Chronic.
Why?
No.
Because it's only 1 to 2 millimeters.
But in the 1999,
Oh, it would be chronic.
So can it be gingivitis with 1 to 2 millimeters of clinical attachment loss? Cross that guy out. Do you feel that it's aggressive periodontitis based on the fact that it's throughout the whole mouth and it's 1 to 2 millimeters at 45 years old? Nope. Do you think it's refractory perio, where it just keeps marching even though the patient has treatment?
Yes.
Refractory?
Oh, no.
Or chronic? There you go. Yeah. So you see how we kind of have to think critically, but we took our chances of getting this question correct from 20% with 5 choices to 50% with 2 choices. That's the extent of my mathematical abilities. So don't ask me help for math, okay? But if you cross out what you know cannot be correct, you give yourself a higher chance of getting this question, okay? So the best answer here is chronic periodontitis.
And why would it not be refractory? Like, why did we label that out? Sorry.
No, don't be sorry. That's a great question. Okay, so refractory is if we can't get the perio under control. It's like it just keeps going no matter how much we treat
Unstable
this.
every time it progresses.
Yes, every single appointment it's progressing and we can't get it under control. That's exactly right. Versus chronic is like a slow, episodic, right? If it was refractory at 45 years old, we'd expect to see more attachment loss than the 2 millimeters. Good. Okay, which of the following AAP classifications best describes this patient? So based on these answer choices, is it asking you about 1999 or 2018?
2018.
1999.
Case type
All the
is
way.
99. Okay. A case type 0 in 99 is health. Is this patient in health? Cross it out. A case type 1 in 99 is gingivitis. Does he have gingivitis? Nope. Now 2, 3, and 4 are all different varying degrees of severity of periodontitis, okay? So a 2 is 1 to 2 millimeters, a 3 is 3 to 4, a 4 is 5+. What do you think is the best answer for this patient?
2.
Good. AAP case type 2. And number 3, if they're asking for AAP classification and they list the answer choices as stage, are we talking about 1999 or 2018?
2018.
2018. Okay. So what can we cross off right away?
Stage 1.
He's for sure not a stage 4 because he's not missing any teeth due to perio. What else?
Stage 1.
Stage, are you sure?
Oh, no.
Let's cross off stage 3, right? Because that's at least, again, 5+ millimeters. Stage 3 and 4 are both 5+ millimeters of clinical attachment loss. So our only options here are 1 or 2. So if the answer here was case type 2 for 1999, what do you think the stage is going to be?
1.
1. Because stage 1 equates to 1 to 2 millimeters interproximal clinical attachment loss. So our answer is stage 1. Okay, any questions? You guys, I'm so sorry. I'm gonna have to really like cut down on my lectures. There's just so much good stuff to learn.
You're very helpful though, so thank you.
You're very welcome. I'm happy to stay. I'm happy to go over this stuff with you guys all the time, okay?
Thank you.
Yeah, absolutely. And I'm going to talk to Miss Duvall and Miss Klesk about getting you some of the expired Arrestin carpules so that you can just like play with it and see what it looks like, okay? All right, if you have questions, I am here. Just send me an email. And if not, I will see y'all on Tuesday. I hope you have a great weekend.
Thank you, Ms. Mitchell.
Thank you. Bye.